Okay, so today we will discuss about the stroke. So first, discussing about the stroke, we need to we have to need the blood supply of the brain. So that is again very important. The blood supply of the brain is divided into the two things: interior circulation and the posterior circulation. So the posterior circulation is mainly due to the posterior cerebral artery. So posterior circulation is basically due to the posterior cerebral artery, right? While the interior circulation of the brain is consists of the interior cerebral artery and the middle cerebral artery, which is a branch of which is a branch of ophthalmic artery, which is a branch of internal carotid. Internal carotid is a branch of common carotid, right? So so this is the area that is this is a homunculus, right? So sensory and motor homunculus. So the interior cerebral artery supplies the homunculus of the lower limb, high yield stuff, while the middle cerebral artery supply the arm, middle cerebral artery supplies the arm and the face. So anything that lead to the infarction of the middle cerebral artery will lead to the lesion of the face, arm, and the hand, right? And anything that will infarct the inferior cerebral artery will lead to the lower extremity problem, lower extremity sensation and motor problems, right? So the posterior cerebral artery is mainly associated with vision. So if there is a vision problem after the stroke history, which artery is included? Posterior cerebral artery, right? So you have to know these high stuff. Interior cerebral artery, lower extremities, middle cerebral artery, arms and face. So, and the posterior cerebral artery, vision, right? So interior and middle cerebral artery, interior and middle cerebral artery. Is my voice is still clear, audible or not?
Is audible.
My system is not work. My tablet is not work. I don't know what happened. Okay. So interior cerebral artery. Okay. So interior cerebral artery and middle cerebral artery. So they composed of interior circulation, right? While the posterior circulation. I hope it makes some sense. This is high yield. Now I'm going to detail discussion on the circulation, circle of Willis, interior and posterior circulation, right? So just I'm going to scroll it down. So these are watershed zones. So the watershed zones are the cortical border zones areas. So that is in between the middle cerebral artery and the posterior and middle cerebral arteries. So this is one area, this is one area, right? So what is the signification of this, the common location of the brain metastasis, right? So in fact, so these watershed zones, in fact, mainly due to hypoperfusion, hypotension, right? So the shock, any condition, they will particularly, particularly lead to watershed zones in part, right? So there is a syndrome, man in barrel syndrome. So man in barrel syndrome is basically a watershed infarct in which ACA, interior cerebral artery and middle cerebral artery. So the watershed area that is in between the anterior cerebral and middle cerebral artery, the infarct of this area take place. Now will the patient present with proximal upper and lower extremity weakness. Proximal upper and lower extremity, because middle middle cerebral artery supplies arms and face, and anterior cerebral artery supplies lower limb. So that's why the patient present with the proximal upper and lower extremity weakness. So this is known as a man in barrel syndrome. So now is the posterior cerebral artery, as we already know the previous discussion, posterior cerebral artery supply the visual area. Visual area means occipital area. So visual dysfunction and higher order problem with the PCA and MCA watershed and far. Okay, just a minute. So now I'm moving toward the circle of the villus. So again, the high yield one. So this is again a high yield one, right? Okay. So the circulation is divided into two types, right? Interior circulation and the posterior circulation. So interior circulation is composed of interior cerebral artery, right? Internal carotid, and middle cerebral artery, right? So internal carotid artery give rise to the interior cerebral artery. This is internal carotid. So this is internal carotid. Look at that. This give rise to the interior cerebral artery, and this one is a middle cerebral artery, right? So internal carotid is a branch of common carotid, right? So look at this picture again, this one, right? So this is aorta, then the subclavian. So subclavian give rise to the vertebral artery, right? And this
Yes.
arch of aorta, you find that brachiocephalic trunk. So what is arise from the brachiocephalic trunk? Common carotid artery. This one is a common carotid artery. So the common carotid give rise to the internal carotid and the external carotid. So internal carotid artery further give rise to these two high yield vessels, interior cerebral and the middle cerebral artery. You know that which artery is a branch of which one, right? So look at that. So this is vertebral artery. So this vertebral artery from the right side, this vertebral artery from the left side. So these vertebral artery fuse together to give rise the basilar artery,
Basilar.
right? So basilar artery infarct lead to which syndrome? High yield stuff. Basilar artery infarct lead to which syndrome? Locked in syndrome.
Yes.
Locked in syndrome, right? So locked in syndrome due to the basilar artery infarct. We will discuss this syndrome in detail. So the basilar artery locked in syndrome. So locked in syndrome, the only eye movement is preserved. All body paralysis. That is why locked in syndrome, right? So it is due to the basilar artery infarct. Okay. So the vertebral artery give rise to the pica, right? So pica posterior inferior cerebellar. So posterior inferior cerebral artery infarct give rise to which syndrome? High yield. Lateral medullary syndrome. What is another name of the lateral medullary syndrome?
Weinberg syndrome.
Weylenberg. Weylenberg syndrome, the high yield stuff. The artery which is involved, so if is the pica is infarct, the pica is involved in the stroke, then it is lateral medullary or Weylenberg syndrome, right? So one more thing, this basilar artery give another thing. This is inferior cerebellum, ICA. So if ICA is infarct, it will lead to which syndrome? It lead to which syndrome? Which syndrome? Lateral Fontaine syndrome. Lateral Pontine syndrome, right? Pica is
Yes.
involved. Which syndrome? Lateral medullary. Lateral medullary. And if it is Ica is involved, then it is lateral pontine syndrome. So the lateral pontine syndrome, the most high yield thing related to the lateral pontine syndrome is a facial nucleus. So the facial nucleus is particularly high yield. That is the facial nucleus affected due to this artery involvement. While in case of if the posterior inferior cerebral artery is infarct, it will lead to lateral medullary or Weylenberg syndrome. Which nucleus is highly affected in lateral medullary syndrome? Which nucleus?
The
Nucleus
ambulance.
ambiguous. Nucleus ambiguous. Right? Okay. So basilar artery, which syndrome? Locked in. Basilar artery, ICA, lateral pontine syndrome, facial nucleus. While if it is posterior inferior cerebral artery, it's the lateral medullary syndrome. Okay. So this vertebral artery gives rise to another artery that is known as an interior spinal artery. If interior spinal artery or vertebral arteries are infarct, it will lead to which syndrome? Which syndrome?
Medial, medial
Medial,
lateral.
medial,
Uh,
medial medullary syndrome.
yeah.
So medial middle. Don't worry about these syndrome. We will discuss these syndrome in detail. So high yield things about you have to identify these syndrome and identify the artery that is involved in these syndrome. Right? I hope it
Okay.
makes some sense. Right? So interior
Yes.
spinal artery, if it is small, it will lead to the medial medullary syndrome. Right?
Yes.
Okay, so let's moving. So basilar artery, it gives rise to the pontine branches. So it's the superior cerebral artery that supplies to the cerebellum, and then it is the posterior cerebral artery. The posterior cerebral artery is arise from the basilar artery, right? So this posterior cerebral artery give rise to this one posterior communicating artery, right? So this posterior communicating artery and this this posterior communicating artery connect the posterior circulation with the interior circulation, right? So this internal carotid give rise to interior cerebral artery, and this one is a middle cerebral artery. So this interior cerebral artery is connected by from right side to left side by another communicating artery that is known as interior communicating artery, right? So if the of infarct of the interior cerebral artery takes place, so how will the patient present? Can anybody tell how will the patient present if the infarct of interior cerebral artery? We already discussed about these things. Interior cerebral artery supplies which brain areas? Which brain areas? Lower extremities. Lower extremities. The patient may present with the lower limb extremities, sensory loss of the lower limb, and urinary incontinence. Right? So give you these kind of the clinical feature on the on your exams, and you have to identify the territory, the artery, right? If the middle cerebral artery, this one is occluded in the scope, how will the patient present? How will the patient present? So the sensory and motor loss of the face and the upper limb So if it is involved in the dominant side, usually the left hemisphere, it will may present with aphasias, Wernicke aphasias, right? Okay. Can anybody tell me about the lacunar infarct? Lacunar infarct.
Yeah, that will involve the lenticular striae.
Excellent. That is due to the lenticulostriate artery, right? So
Yes.
it may be if it involvement of the thalamus will present the pure sensory stroke, while the involvement of the internal capsule will lead to pure motor stroke. And what is the pathophysiology? Sometimes they want to know about. It is due to the fancy term lipohyalinosis, which is simple microathyroma. It is the athyroma, right? So you have
Yeah.
some sense the interior circulation and posterior circulation, and which syndrome are associated, which artery. Should we move now? Should we move now? I think just give me 1 minute. I'm going to change the slide. Just 1 minute. 1 minute. Is my new slides are visible or not?
Not yet.
I think visible. Not visible. Still not visible.
Yes, visible now.
Okay. So what is a stroke? Can anybody define? What is a stroke?
Yes, stroke will basically be a nerve damage due to the inavailability of oxygen
Is a
supply.
nerve damage? What you say? Stroke is?
Yeah, that'll be like you have basically
It's
a
more precise.
neurodeficit.
It's a neuronal, irreversible neuronal injury. Irreversible neuronal injury after the 5 minutes of hypoxia, right? So the stroke is irreversible. It is a irreversible. The first key thing. Irreversible and due to after 5 minutes of hypoxia, right? So the time is money. That's why time is money. The early the patient receives the intervention, the better the prognosis, right? If they delay to reach the hospital and receive intervention, the worst is a prognosis because the time is a money. Okay. So most vulnerable area of the brain that is susceptible to the hypoxia is hippocampus. Which one?
Hippocampus.
Hippocampus, right? So, first investigation in the stroke is CT. What is the role of the CT? Non-contrast CT. Can anybody tell? Does CT identify the ischemic stroke? Does CT scan identify the ischemic stroke?
No.
No. So it cannot identify the ischemic stroke. What is the role of CT? To exclude the hemorrhagic shock. To exclude the hemorrhagic shock. Why it is important? Why it is important? Because we give TPA, thrombolysis, right? If it is a hemorrhagic stroke, that is thrombolysis are contraindicated. Thrombolytics drugs are contraindicated. If it is ischemic stroke, then TPA is useful. Then TPA is helpful for that patient, right? Now you got why CT is important and why early CT is important. CT does not identify the ischemic stroke, but it will exclude the hemorrhagic stroke. But it will exclude the hemorrhagic stroke, right? And this is very important to give the patient TPA at the right time, right? So what kind of the necrosis take place in the stroke? Liquefactive necrosis.
Liquefactive in the brain, yes.
Liquefactive necrosis, right?
Yes.
Okay, liquefactive necrosis. This is again a high yield. So sometimes they give you that a histopathology picture of the stroke, and they want to know the mechanism of the liquefactive necrosis. What is the mechanism of the liquefactive necrosis? Is basically due to liquefactive necrosis, basically due to the lysosomal enzymes, due to the release of lysosomal enzymes from the inflammatory cells as well as from the damaged cells. So the very high yield point give you the clinical vignette of the strokes, weakness and sensory areas, and they give some sort of the picture. And what is the mechanism? What is the mechanism of this picture? What is the pathophysiology of this picture? So what is the pathophysiology? The lysosomal enzyme. So the lysosomal enzyme released from the inflammatory cells and the damaged cells, right? I hope it makes some sense. Okay, before going to classification of the stroke, one a simple terminology. What is a transient ischemic stroke? What is a transient ischemic stroke? You found this kind of stuff in many times. Transient ischemic stroke. It is basically the short reversible episode of the focal neurological deficit, right? So it is a reversible, short reversible. Majority of resolving within less than 15 minutes. It may present with a transient visual loss. It may present with the transient visual loss, right?
Yes.
Right?
Yes.
Okay. So what is the ideal time to give the patient TPA? Excluding the contraindication by using the CTA, CT scan, and detailed history of that patient, right? And another, it is a time. If it is a within 3 to 4.4 hour onset, this is again a high yield stuff. 3 to 4.5 hour of onset, right? Okay. Now moving toward the classification of the stroke. So the stroke is simply divided into two types. Ischemic stroke. Which one is the most common? Ischemic stroke is the most common type of the stroke, right? And the second one is hemorrhagic stroke. Hemorrhagic stroke is a less common type of the stroke, right? So hemorrhagic stroke is further divided into four types, simply divided into the four types. So first one is intraparenchymal hemorrhage. Intraparenchymal hemorrhage is highly associated with hypertension. Epidural. Epidural is associated with middle meningeal artery. Epidural is associated with middle meningeal artery, which is a branch of maxillary artery, right? And subdural. Subdural is due to rupture of bridging vein. Rupture of bridging vein. And subarachnoid hemorrhage. So the subarachnoid hemorrhage is most highly associated, most commonly high is aneurysm, right? Aneurysm. Intraparenchymal hemorrhage. Intraparenchymal hemorrhage is associated with hypertension, right?
Yes.
Okay. So subdural hemorrhage, middle meningeal artery, ischemic stroke. So can anybody tell how will the patient present with a middle meningeal artery, and which investigation is used for these hemorrhagic strokes? CT.
I think we get those CT scan, yes.
Okay. So again, their CT scans are high yield. Their CT scans are high yield, right? So just give me 1 minute. I'm changing the slide and going towards the CT scans of these high yield stuff. Just give me 1 minute with the CT scan. Okay, just 1 minute. Question. Neurology. Is my screen is visible or not?
Not here.
Okay. So epidural hemorrhage. We already discussed about the epidural hemorrhage. So epidural hemorrhage is highly associated with rupture of the middle meningeal artery. So middle meningeal artery is a branch of maxillary artery, right? So it is due to the skull fracture, basically the pterion, which is the thinnest area of the skull, right? So it presents with a lucid interval. What is a lucid interval? So it is a transient loss of consciousness with recovery, and then rapid deterioration due to the hematoma expansion. Okay, let's look at the picture. This is CTs, a super high yield CTs of the USMLE Step 1. So on the picture of the CT scan, you noted that biconvex lentiform. So biconvex lentiform on the CT scan, history of the trauma, lucid interval. What you will think? 3 things: lucid interval, trauma, and biconvex lentiform. Biconvex lentiform on the CT. So white things are hyperdense, blacks are hypodense. So this not crossing the suture line. Okay. So this is again. So this arrow show. What does the arrow show? Scalp hematoma. Scalp hematoma, right? And this kind of the epidural hemorrhage or epidural hematoma may lead to the transtentorial herniation and cranial nerve 3 palsy. So the cranial nerve 3 palsy is highly associated with epidural hematoma, right? So their CT, again, epidural hematoma, three things. Lucid interval, history of the trauma, right? And biconvex or lentiform shape on the CT. And sometimes the cranial nerve tree palsy, right? Does it make some sense? Rock,
Yeah.
does it make some sense?
Yes. Okay. Can you just, where you have the red arrow, can you just run over that one more time?
Okay, so this thing shows, this circle shows that skull hematoma, right? This
Right.
one. And this thing, this hyperdense area shows biconvex lentiform, right?
Okay.
So these are findings that suggested that the patient, and further the history is very important, the trauma, right? And the lucid interval. Not simple CT. You have the exam typically give you the clinical vignette that the young guys with the RTA receive the skull trauma, and on examination, the patient had transient loss of consciousness with the recovery, then the rapid deterioration. These kind of the clinical vignette explain in detail, right? And they give
Okay.
you the CT, right?
Yes.
So what is the treatment of this epidural hematoma? It is burr hole, right? So burr hole is a treatment for epidural hematoma, right?
Yes.
So next moving toward the subdural hematoma. Okay, so subdural hematoma. So the subdural hematoma is due to the rupture of bridging vein. Okay, how they give you that? They give you the CT, and they sometimes they ask about what is the mechanism. If they give the epidural hemorrhage CT, they love to ask which thing is damaged. So which thing is damaged? The artery. Which artery? Middle meningeal artery, right? Middle meningeal artery, right? So the subdural hematoma, it is due to the rupture of the bridging vein. Rupture of the bridging vein. It may be due to acute, and it may be due to the chronic, right?
Yes.
Okay. So if it is acute, it is due to the trauma. And if it is chronic, it is a mild trauma, cerebral atrophy, aging, and chronic alcohol overuse. So subdural hematoma is divided into the two things: acute presentation and the chronic presentation. Acute presentation is associated with trauma. Chronic presentation is associated with mild trauma, cerebral atrophy, increased age, and on chronic alcohol overuse. So this chronic is hypodense. Chronic is hypodense on CT. And this chronic is also seen in
Doing,
shaken baby,
I
right?
doing, I doing, mom. I doing. I'm sorry.
Right? So again, the CT is very important. The CT is, look at that, the CT in the picture C. The CT is a typical crescent shaped CT. The typical crescent shaped CT is the CT of the subdural hemorrhage, subdural hematoma. And it is crossing the suture lines, and it can cause the midline shift. Yeah, right? The pictures see
Yes.
that it is acute on chronic. So this is hyperdense, hyperdense crescent shaped hemorrhage, and this black is hypodense. Hypodense means the chronic hematoma, the chronic, which is associated with increased age, alcohol overuse, cerebral atrophy. So it may present with acute on chronic, it may present with the acute presentation. Again, they give you the clinical vignette on the exam, and they want to know about the which is the underlying pathology. What is the underlying pathology of the subdural hematoma is? Rupture of bridging vein. So these CT are the most super high yield CT for the USMLE Step 1, right? For subdural hematoma is a crescent shape, while in the extradural or epidural, epidural also known as a extradural hematoma or hemorrhage. So it is epidural extradural. It is biconvex or lentiform, right? Okay, just a 5-minute break and we will back to complete the stroke today, right? Just a 5-minute break, right?
Okay.
Okay, let's begin this session. The subarachnoid hemorrhage. The subarachnoid hemorrhage is due to the rupture of aneurysm, which due to the trauma, right? Or it may be due to AV malformation. So subarachnoid hemorrhage due to AV malformation and aneurysm, right? So,
Yes.
so aneurysm is a high yield. Why it is a high yield? Because they give you the history of the polycystic kidney disease. Autosomal polycystic kidney disease is associated with it is
Aneurysm. Yes. Very aneurysm.
so autosomal polycystic kidney disease is associated with berry or secular aneurysm. So subarachnoid hemorrhage is common in polycystic kidney disease. Very, very high yield stuff. Very, very high yield stuff. Right? So
Yes.
subarachnoid hemorrhage is associated with autosomal
Very
polycystic kidney disease.
Yes.
Autosomal polycystic kidney disease is associated with berry aneurysm. And due to this
Okay.
rupture of this berry aneurysm, it will lead to the subarachnoid hemorrhage. Right?
Okay. Yes.
If
Now, what chromosome? What chromosome is that on?
what chromosome? Still, I am not remember which chromosome, but you remember autosomal polycystic kidney disease, right?
Okay. Okay.
If people are still joining. Uh, okay, so how the patient present? Worst headache of my life. So the worst headache of my life is a subarachnoid hemorrhage. On lumbar puncture, you see the bloody or yellow, yellow CSF, right? Bloody or yellow CSF. Okay, so the vasospasm occurred. Vasospasm occurred due to the blood breakdown. Vasospasm occurred due to the blood breakdown and rebleed occurred 3 to 5 days. So how will you prevent this vasospasm or rebleeding? Nimodipine. Nimodipine is which class of drug? High yield stuff. Nimodipine is a which class of drug?
That's a calcium channel blocker.
Calcium channel blocker. Very high yield stuff. They give you the scenario, clinical minute, and they didn't want to know the nimodipine. They want to know the mechanism of action, right? So
Yes.
vasospasm is reduced by calcium channel blocker. So increased risk of developing communicating or obstructive hydrocephalus, right?
Yes.
Intraparenchymal hemorrhage. So intraparenchymal, I already discussed intraparenchymal hemorrhage is highly associated with hypertension. Hypertension, right?
Yes.
Okay. So, uh, so we already discussed about these things. Lacunar infarct, right? Lacunar infarct. If it is due to the thalamus, it is lead to which kind of sensory or motor?
Sensory.
Sensory. If it is Internal capsule,
Motor.
motor, high yields, right? So, what is the mechanism of the lacunar infarct? Atheroma, microatheroma. What is the fancy term for microatheroma?
So what is the what?
So lacunar infarct, sometimes they give you this kind of lacunar infarct and they want to know about the pathophysiology of the lacunar infarct. It is a microatheroma. Microatheroma is also known as a lipohyalurosis. Sometimes they give the lipohyalurosis is also known as a microatheroma, right?
Okay.
So this interparenchymal hemorrhage is also seen in amyloid angiopathy, right? It is associated with AV malformation, vasculitis neoplasia, right? And these hypertension hemorrhagic infarct is also associated with some other structures. Putamen, globus pallidus, basal ganglia. These are again lenticulostriate vessels, followed by the internal capsule, thalamus, and the cerebellum. So this is a cerebellum infarct, and this is due to the lenticulostriate vessels, right? So this is a hyperdense area on the CT, right? Let's moving toward the ischemic infarct. After the completing this stroke, we have some clinical vignettes, and you have to solve these clinical vignettes, right? By basing on these knowledge. Okay. So ischemic stroke. Ischemic stroke. What is the treatment of the ischemic stroke? If less than 3 hours, give them TPA. If more than 3 hours, what will be the drug? Is most important. Give them aspirin. Give them aspirin. Acetyl salicylic acid. Right? I hope it makes some sense.
Yeah, we say to give after 3 hours to give them what?
3 hours, give them aspirin. If less than 3 hours, then TPA.
TPA. After 3 hours, heparin, right?
Aspirin. If the patient has history of atrial fibrillation, then you have to anticoagulate that patient. Atrial fibrillation, right? So the stroke risk factors are hypertension is the most common. Atrial fibrillation is again the risk factor. Atrial fibrillation. So which one is the most important? Atrial fibrillation. Because atrial fibrillation most likely to cause the stroke because of stasis in the left atrium and thrombus formation, and that thrombus will occlude the brain vessel, right? So this is again a high yield. Atrial fibrillation is most chances to cause stroke, but hypertension is the most common risk factor. But most likely chances to cause stroke is atrial fibrillation, right? Okay, so these are some histopathological changes, and you may aware of these things. 12 to 24 hours. So the red neuron is basically the eosinophilic cytoplasm and pycnotic nuclei. 24 to 72 hours necrosis plus the neutrophils. So sometimes they give you the timeline 24 to 72 hours of the stroke, and 3 to 5 days the macrophages or the microglia, right? And 1 to 2 weeks reactive gliosis and astrocyte and vascular proliferation. and more than 2 weeks, glial scar. Let's move toward the most high yield stuff of the stroke. These are the some syndromes. Most high yield stroke. Okay, so anterior circulation, we already discussed these things in previous session, right? So the interior circulation composed of in these vessels, right? Interior cerebral, middle cerebral, interior cerebral artery supplies the lower limb, lower limb. So if the impact of the interior cerebral artery, the patient typical presentation with the lower limb, sensation and motor loss and urine. If the middle cerebral artery, we already know that face and upper limb. The face and upper limb sensation and motor weakness in the middle cerebral artery infarct, right? So if it is a dominant, it may lead to aphasia, middle cerebral artery. If it is Wernicke area is damaged, so it's a Wernicke aphasia. If it is a Broca, then it is Broca aphasia. Wernicke aphasia is sensory aphasia. So what is problem in Wernicke aphasia? Can anybody tell? His understanding is intact in Wernicke aphasia. So Wernicke aphasia is sensory aphasia. So this is a sensory aphasia, right? And this is motor aphasia. So here is a understanding is impaired in Wernicke area, while understanding is preserved in the Broca area. The motor problem, articulation problem, verbalization problem, right? So aphasia takes place if it is dominant side infarct, if it is involvement of the left hemisphere. Heminegnect if lesion is non-dominant, right? So Wernicke aphasia is associated with right superior coordinate visual field defect due to the temporal lobe involvement. So we already discussed about the lenticulostriata vessels. These are internal capsule, thalamus and striatum, right? So the pure motor stroke due to the internal capsule. And if it is thalamus involvement, it is a pure sensory stroke. And the underlying pathophysiology is microathyroma. Microathyroma is simply lipohyalurosis, right? This is some repetition of the previous session. So you already know about the artery and the area that is supplied by, right? So posterior cerebral artery is highly associated with the occipital lobe. If occipital lobe is damaged, what will happen? What will happen? Patient present
Problem
with
vision.
Patient present
Vision
with
loss.
vision loss.
Vision.
They give you the history of the stroke. Patient present with the visual loss. So which artery is included? Posterior cerebral artery,
Cerebral.
right? So contralateral hemianopia with macular sparing, right?
Okay.
Presbyopia. What is the presbyopia? Can anybody tell?
Can you repeat the question?
Presbyopia. What is presbyopia?
Like inability to recognize.
Okay, you are absolutely right. It's the inability to recognize face, right? So if it is a dominant hemisphere infarct, so it will lead to the contralateral hemianopia with macular scarring and alexia, right? And if it is non-dominant hemisphere, they present with prosopagnosia, inability to recognize face. So it is also known as a face blindness. Weber syndrome. What is a Weber syndrome? Is a midbrain stroke. Which artery is occluded? posterior cerebral artery, mainly the paramedian branches. Right?
Yeah.
So Weber syndrome, mid-brain stroke due to the occlusion of posterior cerebral artery, ipsilateral cranial nerve third palsy, and contralateral hemiplegia. Right?
Right.
Okay, basilar artery. We already discussed locked-in syndrome. Complete paralysis in locked-in syndrome, except eyes, right? So
Yeah.
you have to identify these things. Basilar artery, infarct, locked-in syndrome. Okay. So if it is ICA, ICA is a branch of, can anybody tell? ICA is a branch of inferior cerebral artery, is a branch of basilar artery,
The
right?
basilar artery.
Basilar
Yes.
artery. So it in fact leads to the lateral pontine syndrome. The lateral pontine syndrome, the facial nuclei are affected, specific to ICA lesion, while in the posterior inferior cerebral artery, which is a branch of vertebral artery, right?
Yes.
ICA lesion lead to which syndrome? ICA lead to
No, Wallenberg.
Wallenberg. Wallenberg is another name of
Lateral medullary.
lateral medullary, and ICA lead to lateral pontine.
Pontine. Yes.
Anterior spinal artery is occluded, which it will lead to medial medullary syndrome. We already discussed these things, right? So the key
Yes.
thing to identify the lateral pontine syndrome, facial nerve, right? So involvement of the facial nuclei. So the only key difference between lateral medullary and Wallenberg is facial nucleus and hearing loss. So this is confusing thing. You have to differentiate between, just give me the lateral pontine syndrome and Wallenberg. So in Wallenberg, nucleus ambiguous. So dysphagia, degrees reflex in Wallenberg. While in lateral pontine syndrome, facial paralysis, right? And ipsilateral sensory neural deafness. So if the remaining feature of lateral pontine syndrome and Wieland-Banach syndrome are same. The only difference, these things. These are high yield, right? I hope it makes some sense. Does it make some sense?
Well, I think we have to go over it. It's about
Okay, this is
to
the
read
most
and
difficult.
understand.
This is the most difficult thing in the neurology. So I am only highlighting the key features, right? So all of these things, all of these things are take place in Wallenberg as well, right? All of these things are also take place in the Wallenberg, right? So, but only these things are differentiating facial and inner ear pathology. So these are the hallmark of the lateral pontine syndrome. I'm highlighting the key differences. Did you understand
Okay.
how to differentiate the Wallenberg syndrome from the lateral pontine syndrome? Basis on these things. Let's move the posterior circulation. Just a minute. Okay, so the posterior, it's the posterior inferior. So posterior inferior cerebral artery, which is a branch of, which is a branch of vertebral artery. So this is lateral medullary Wielenberg syndrome. So the nucleus ambiguous. You noted that all of these things are same as in lateral pontine syndrome. The only difference is the nucleus ambiguous. Nucleus ambiguous is a nucleus that contains cranial nerve 9 and 10. So the dysphagia, hoarseness, and decreased gag reflex. So that's why these things are highlighted. These are key things that you have to differentiate from the lateral pontine syndrome from the lateral medullary syndrome, right? So let's moving to the interior spinal artery. So the interior spinal artery, this is occluded, will lead to the medial medullary syndrome, right? Medial medullary syndrome. But will medial medullary to the corticospinal tract, medial lemniscus, and caudal medulla. So medial lemniscus basically contain the sensation of the dorsal column. Dorsal column sensation are the proprioception, fine touch, 2-point tactile discrimination. So these kind of this sensation are decreased in medial medullary syndrome. Corticospinal tract, so the paralysis, contralateral paralysis, contralateral proprioception loss, and the caudal medulla hypoglossal nerve, right? So the hypoglossal nerve dysfunction takes place in medial medullary syndrome, right? So the medial medullary syndromes, medial lemniscus or corticospinal tract are hallmark of medial medullary syndrome. Let's moving towards some high-yield clinical winners. Are you ready for that clinical winner? You have to identify the diagnose and the key things in that one. Just give me a 1 minute. The next on stroke. Is my screen is visible on Winnet or not?
Not yet.
Is visible? Rob, can you read it
Yes.
for me? Winnet 1.
Okay, can you blow it up a little bit, please?
Just give me 1 minute.
Okay. Yeah.
Please read it.
Okay. So, Vignette 1, 54-year-old woman presents to the emergency department with a sudden severe headache described as the worst headache of her life. She also reports nausea, vomiting, and neck stiffness. On examination, she has photophobia and a positive chronic sign. Her medical history is significant for hypertension.
Identify the diagnosis.
Okay, so this will be a subarachnoid hemorrhage.
Can you tell me the high yield association of this hemorrhage?
Well, yeah, so she's complaining of the worst headache of her life. We know that the meninges are engaged because she has neck stiffness, which reflects in the positive chronic sign. So that means that she has pain
Okay,
if you
so,
have to.
so you noted that this patient is suffer from the subarachnoid hemorrhage. So subarachnoid hemorrhage is highly associated with autosomal polycystic kidney disease.
Kidney
Autosomal
disease.
polycystic kidney disease is associated with berry aneurysm, right? So
Yes.
this is high yield. Moving to the vignette 2.
Unit 2. A 67-year-old man is brought to the hospital after experiencing sudden weakness on the right side of his face. I'm sorry. On the right side of his body, including his face and arm. He also has difficulty speaking and is unable to repeat simple phrases. His past medical history includes type 2 diabetes and hyperlipidemia.
Okay, so can anybody tell me which artery is involved in this stroke?
Yes, so I think this would be the middle cerebral artery.
Okay, so this is a middle cerebral artery. Which side? Right or left side?
Okay, let's see. Difficulty speaking language, so that will be on the left side.
Excellent. Okay, so this is a which aphasia? Which aphasia?
Okay, so difficulties speaking, so that will be the Broca.
Okay, so this is a broca, difficulty speaking, right?
Yes.
Okay, move to the winner 3.
Number 3, 45-year-old woman complains of sudden onset of visual disturbances. She describes seeing only the left side of her visual field from both eyes. There is no history of trauma. Her past medical history is unremarkable. Okay.
So which artery is
So,
included?
okay, that will be posterior cerebral
Posterior
artery.
cerebral artery.
Posterior cerebral artery, right? Okay, let's move to the vignette 4.
Vignette 4, 60-year-old man with a history of smoking and hypertension presents with sudden onset weakness in his left leg and urinary incontinence. He denies any trauma or preceding illness. Physical examination reveals decreased strength in the left lower extremity and brisk reflexes.
Which artery?
Anterior cerebral artery.
Just give me 1 minute. Just do 1 minute. Okay. Can you please read it? We have short time.
Which one? I think somebody answered. Are you okay? We'll move to the next vignette.
Vignette 5.
Okay. 70-year-old woman with a history of atrial fibrillation presents with sudden onset right-sided weakness and numbness, primarily affecting the leg more than the arm. She also has difficulty initiating urination. There is no history of trauma or previous similar episodes.
Okay, which artery?
I think this will be anterior cerebral.
Okay. So if the patient has lagged anterior cerebral, atrial fibrillation has most likely caused to stroke when you compare with the hypertension. This is again high yield point. Although the hypertension is the most common risk factor, but the atrial fibrillation has highest chance to cause stroke. Clinical vignette 6.
62-year-old woman presents to the ED with sudden onset of vertigo, nausea, and vomiting. She reports that her symptoms started approximately 3 hours ago while she was at home. On physical examination, she exhibits decreased gag reflex, unsteady gait, and has difficulty standing without support. Neurological examination reveals horizontal nystagmus, dysmetria, on finger to nose testing, and diminished sensation to pain and temperature on the left side of her face and right side of her body. She has a history of uncontrolled hypertension and hyperlipidemia. There is no history of trauma or recent illness.
Okay.
Okay.
So which arteries included? Which arteries excluded?
Let's
Is that
go on this.
posterior inferior cerebellar artery?
Yes, excellent. So first you have identify the patient is suffer from which problem. So it is Wielenberg syndrome. How you can identify the Wielenberg syndrome? By the
The
decreased gag reflex. This thing, gag reflex is a key thing. Gag reflex, dysphagia, this kind of the stuff, right? So
Mhm.
if
Okay.
this gag reflex is a gag reflex problem, and they mention in spite of the gag reflex, facial paralysis plus sensory neural deafness. So which vessel is involved? Which vessel is included? Similar presentation, except removing the gag reflex and adding the facial paralysis in that vignette plus sensory neural deafness, right? So which artery is included now in this vignette?
Anterior inferior cerebral artery.
So which syndrome is?
Lateral pontine.
Which one?
Lateral pontine syndrome.
Yes, lateral pontine syndrome. So lateral pontine syndrome is most highly associated with facial nucleus, right? Facial nucleus is affected. So the last vignette is vignette 7. So this point is a high yield to differentiate the Wielenberg from lateral pontine. I already explaining these things in my review session, right? So you have to differentiate Wielenberg from the lateral pontine. Clinical vignette 7.
65-year-old man presents to the ED with sudden onset of dizziness, nausea, and vomiting. He also reports double vision and difficulty swallowing. On examination, he has nystagmus, ataxia, and an unsteady gait. There is ipsilateral facial paralysis, loss of pain, and temperature sensation on the right side of his face, loss of pain and temperature sensation on the left side of his body. He also has ipsilateral hearing loss and tinnitus. His medical history includes poorly controlled hypertension and smoking.
Okay, which vessel is included?
Anterior inferior cerebellar artery.
What will be the diagnose?
Excuse me?
Lateral
Diagnose of
pontine.
this vignette.
Oh, the lateral pontine syndrome.
Okay, lateral pontine syndrome, right?
Yes.